Welcome to everyone to Basic AP Arrhythmia course. I'm Dr. BENAICH Fatima AZZAHRAE from Morocco, and I'm very honored to be with you to introduce this nice topic of isthmus-dependent macro-reentrant tachycardia in normal heart. So atrial flutter is one of the most common cardiac arrhythmias in human. It is a distinct clinical entity characterized by macro-reentrant mechanism. In the past, flutter has been defined as either typical or common, which is characterized by a negative deflection in the inferior leads and positive one in the V1, or atypical or uncommon flutter characterized by a positive notched deflection in inferior leads and negative one in V1. After that, in 2001, the expert consensus agreement proposed that macro-reentrant atrial tachycardia may be classified into two categories. We talk about typical flutter, which is an isthmus-dependent or tricuspid cabal isthmus-dependent atrial flutter, and atypical one, which is non-isthmus dependent, or if you want, leisure scar-dependent atrial flutter that is related to prior surgery, prior ablation, or any underlying heart disease. So our focus in this topic will be about isthmus-dependent atrial flutter, which is divided into two types: the clockwise isthmus-dependent and the counterclockwise isthmus-dependent. So if you want to make an accurate diagnosis of macro-reentrant circuits and to achieve a successful ablation, understanding of the normal CTI anatomy is mandatory. So as you see, CTI is bounded anteriorly by the tricuspid annulus and posteriorly by the IVC, the eustachian ridge, and we have the crista terminalis here also. So the myocardial fibers and the CTI has a circumferential orientation, and they merge with the ostium of the coronary sinus. Posteriorly, the eustachian ridge continues onto the interatrial septums as the inferior limbus of the fossa ovalis. CTI has a quadrilateral shaped. Right. So CTI has a quadrilateral shaped area. Medially, we have the paraseptal isthmus, and laterally, we have the inferolateral isthmus, and in the middle, we have the central isthmus. Our best knowledge of the CTI anatomical characteristics helps us to choose the best area for ablation. So for a short ablation time, we will look for the shorter distance. So as you see, the CTI becomes broader, more laterally by approximately about 6 millimeters. The second criteria is the thickness of the CTI that varies along its course, being thinner in the center isthmus with variable thickness laterally because of this traversion, as you see here, of pectineate muscle. So clearly we can conclude that inferior lateral isthmus is not really the ideal area for ablation. We still have the central isthmus, which is the thinnest one, and the paraseptal isthmus, which is the shorter one. So here, septally, we notice that the CTI is close to the cocked triangle. What does it mean? Close to the compact AV node and the fibers of the slow Y. And anteriorly is close to the branches of the right coronary artery and the small cardiac vein. So we need successful ablation, but with no or less complication. That's why the central isthmus is the best area for ablation. Let's talk about ECG. I want to share with you the most relevant case in the lecture of the ECG, and you know that ECG takes an important role in the diagnosis and also in some level in the classification of atrial flutters. So typical flutter wave has a well-known sawtooth pattern in the inferior leads. The F waves, as you see here in this two example of ECG, is an organized atrial activity with uniform and evenly spaced each tooth, filling space between the QRS complex. The ventricular rhythm may be regular if we have a fixed level of AV block, or irregular, as here, if we have a variable level of AV block. So the first question when we have ECG about atrial flutter is, could we distinguish between isthmus-dependent and non-isthmus-dependent flutter, because this is very important to define the manner of ablation that will be conventional or using 3D mapping. So yes, of course we can do it, but just remember that in this topic we are talking about atrial flutter in normal heart. It means that we have no prior surgery or ablation, and in other words, do not have any intra or interatrial conduction disease. So we will check the polarity in V1 and V6, and we will see if we have concordance or non-concordance polarity. If V1 and V6 have the same polarity, so as you see in this example here, we have a positive deflection in V1, positive in V6, and also in the inferior leads. So here we have in front of a non-isthmus dependent atrial flutter. But when we have a discordance between V1 and V6, or V1 and inferior leads, here we are talking about isthmus dependent atrial flutter. As you see in this example, we have negative deflection in the inferior leads as in V6, but it's positive in V1. So the ECG pattern of the counterclockwise atrial flutter. So as you see, the circuit on our left, the circuit of the counterclockwise flutter is a broad activation wave front rotating in counterclockwise direction with ascending activation in the septum and descending one in the lateral wall. And on our right, we have this nice presentation and demonstration with high density activation map showing the circuit with this color code from the red one to the purple and counterclockwise rotation. And also the 3D mapping helps us to delineate a region of functional block, as you see with these arrows, and that represents the crista terminalis between the SVC and the IVC. In the middle, we have the classic feature of counterclockwise atrial flutter in the ECG with negative deflection in the inferior leads, as we see exactly here, and positive one and V1. And the important things that you will notice in the inferior leads, it's this slight descending plateau phase. And this one is correlate with the conduction time and the cavo-tricuspid isthmus. And just after, we have this sharp negative deflection correlates with the wavefront's penetration of the septum with ascending depolarization of the septum and the anterior walls. And at the end of the negative shape, we have this positive notch, which is a subject of several discussions. It seems that correlates with the activation of the anterior wall, but also if you see in V1 that coincides with the positive deflection in V1. So this classic appearance of ECG may show some morphologic variation. And here we have a retrospective study of 152 ECG, and they found three patterns of ECG defining three groups, depending on the characteristic of this positive notched preceding the plateau phase, as you see in the inferior leads. So we have the first group with purely negative deflection in the inferior leads, and as you see here, we really not have this positive notched here. The second group, we have a negative deflection followed by positive that are approximately of equal sizes. And the third group had a small negative followed by positive deflection of greater amplitude with in V1 a broad positive deflection in V1. The activation map of the right atrium and this tree group were the same, but they noticed that there is some difference. The first group was younger with no heart disease. The second group and the third group, they was older with a history of atrial fibrillation and with the large left atrium. So they concluded that this ECG pattern, especially the positive deflection after this sharp deflection and the inferior leads, could identify a patient population with a relatively high likelihood of heart disease, left atrium enlargement, and high incidence of atrial fibrillation. So they conclude that the isthmus-dependent flutter is a right atrium phenomenon, but the ECG patterns, especially in the counterclockwise flutters, is related to the propagation to and through the left atrium. So here we have the example of the clockwise atrial flutter. So we have the same anatomical circuit, as you see, with septal descending activation and with ascending activation of the lateral wall. So we have in the ECG, we have a positive deflection in the inferior leads and negative one in V1. As you see with the high mapping, with the high density activation map, the color code show a clockwise activation from red to purple. Here we have a clockwise activation around the tricuspid valve. And what I want to point here is the notch. It's a positive deflection in the inferior leads that could make some misleading diagnostic, if you want, with this third group that they have a predominantly positive deflection. But for clockwise, we have this notch. That was explained by the activation and the predominantly activation of the left atrium over the Bachmann bundles, because the circle is in the clockwise manner. So we have first activation of the left atrium by Bachmann bundles here, and consequently by the coronary sinus. And this classical pattern, and the same study, they found two groups with the classical patterns, as we see, positive in the inferior leads and negative in the V1. Also, of course, the same polarity in the inferior in the V6, the V5. And the second appearance were of continuous regular positive undulation, but they didn't find any difference between these two groups regarding age, heart disease, left atrium enlargement. And the explanation was because of the major activation of the left atrium over the Bachmann bundle. So after ECG, the characteristic, so we noticed that appropriate interpretation of the surface ECG can suggest specific types of atrial flutters, but programmed simulation and activation mapping determine the mechanism and critical sites for ablation to achieve a successful ablation. So during EP study, we have some steps that they are very important to respect. The first one is the catheter's position. As you see in this view, we have the multipolar hollow catheter with 20 pole positioned in the right atrium anteriorly, not posteriorly, to record the circumference of the tricuspid valve. And we have the distal part, and the LAO is towards 7 o'clock. The decapolar catheter of the coronary sinus is positioned into the coronary sinus. And as you see, with the proximal electrode bracting in the ostium of the coronary sinus, just imagine if you push the CS catheter deep in the great cardiac vein, you could have like a distal proximal activation or like a chevron pattern activation, like simultaneous activation of the proximal and the distal part of the coronary sinus, and that can make some misleading diagnosis. So the position of the catheter is something of important step in our study, and the catheter ablation is pointed towards 6 o'clock in LAO view 45 degree. So before ablation, so ablation is done during atrial flutter. So the first step, if the patient isn't on ongoing atrial flutter, we have to induce the atrial flutter. And the atrial flutter is reliably induced by programmed stimulation in patients with a history of this arrhythmia in more than 95%. So it's very easy to introduce it. The protocol, we have two kinds of protocol. The first one is using two extra stimulus, is less used. But the second one is rapid atrial pacing, is the most used in our labs. So as you see in this panel, we have rapid pacing. We have rapid atrial pacing. Initially, we see in the hollow catheter like a simultaneous activation of the proximal part and the distal part. That is in the septum, as you see the location here of the hollow catheter. So we have the simultaneous activation because of the counterclockwise and the clockwise wave front, and progressively from the spike to the activation to the atrial electrocardiogram recorded in the distal part of the hollow, we see some delay. We have like the decremental conduction through this part until the block. And once the block happens in the CTI, we initiate the atrial flutter. After inducing, or if the patient is in a ongoing flutter, we have to study the atrial activation sequence. Here we have the two examples of counterclockwise and clockwise. Once on our left, from the top to the bottom, we have a V1, we have lead 2 and the V1, we have the His catheter, and we have here the hollow from the proximal part to the distal part. As you see that the activation here is from the proximal part here, and here we have at 12 o'clock. So this pole is the proximal one, and this one is the distal one. Okay, so we have a proximal distal activation, or if you want, as you see here in this image, craniocaudal activation of the hollow catheter. Okay, and is a sequence one, which and after that we have a delay between this lateral border until the atrial electrogram and the His bundle, and is correlated with the conduction time through the CTI. And activation of the coronary sinus is from proximal to distal. The most important things here is this sequential activation, and that the activation cover the cycle of the atrial flutters. For clockwise flutters, we will have the reverse circle, and we will have like ascending activation from distal to proximal. As you see, it's caudocranial here in the image, with a delay between the His bundle and the isthmus. Let's examine together this panel from the top to the bottom. So we have lead 2, V1, and the hollow catheter placed in the lateral anterolateral until the isthmus here, the lateral isthmus of the CTI, and we have the His catheter placed in the septal place. And as you see, we have a proximal distal activation, but the activation of the septum happens simultaneously as the proximal part of the hollow. So we have an activation in the same time in counterclockwise manner for the lateral wall, and an activation of clockwise manner in the septal wall. So that's this feature suggests a focal activation here with running of the wavefront in two opposite directions. And if you examine the isthmus here, you will see a double potential. So the first depolarization, the first atrial, comes from the counterclockwise wavefront, the second from the clockwise wavefront. So in this case, we put the catheter mapping and the left superior pulmonary vein, and you see clearly a premature activation of the coming from a focal activation coming from the left superior pulmonary vein. That's why it's really important to search for a purely descending activation from the heart with a sequential activation that must cover all the circuit of atrial flutter. So now, after examining the feature of atrial activation, we will start some diagnostic maneuvers. So the whole is to confirm the micro-reentrant circuit is something very important, and to localize, of course, the critical circuit. We know that for isthmus dependent is the CTI, our target for ablation, and is the critical isthmus. We have two techniques. The first technique is using giving extrasystole as at a long coupling interval, as you see in this. In this example, and we try to see if we have a capture. So here we have a capture of atrium, and we will examine the first return cycle length. So if the first return cycle length is equal to the cycle length of the tachycardia, so it means that we are within the circuit. But if that exceeds, it means that we are out of the circuit. This is the resistant phenomenon. It's less used in our lab, but the most used one is the entrainment. And here we have some example about the entrainment. So as you see, we have from the top to the bottom, we have lead 2, V1. We have the hollow catheter here around the tricuspid annulus, the ablation catheter, and the coronary sinus with proximal distal activation. And here we have the proximal distal activation of the hollow catheter and related to the counterclockwise flutter that we have. We see the negative here, wave, F wave, and lead 2. So we start a rapid pacing with a cycle length less than between 10 to 30 milliseconds than the tachycardia cycle length. The first things we need to have an entrainment. It means capturing and advancing the atrial activity, and that is what we are seeing here. So these spikes give this depolarization, and after, at the end of the spike, we will examine the PPI, the post-pacing interval. So if the post-pacing interval is minus the cycle length is less than 30 milliseconds, so it means that we are in the circuit. So in this example, as you see, we have a fusion, a concealed atrial fusion. As you see, that's the atrial depolarization around the hollow doesn't really change from the paced beat to the natural atrial flutter activity. And also the PPI is less than 30 milliseconds. So here we are pacing from the critical isthmus, and we have like a concealed atrial fusion. The second pacing, it was from the distal CS. So we pace from the distal CS, and as you see, we have we are capturing the atrium, and after that, we measure the PPI. And we see that the PPI is more than 30 milliseconds. So that means that we are outside the circuit of the macro-reentrant tachycardia. And in this case, we will have, as you see here in the ECG, we will have like a manifest atrial fusion in the surface ECG, and also in the intracardiac recording with a PPI minus tachycardia cycle length over than 30 milliseconds. The third example here for entrainment, we entrain from the lateral wall of the atrium, and we see that we are capturing the first bits capturing, and the PPI here is really more than 100 milliseconds. So, but if we examine the last paced here beat, we see that we are not capturing the atrium. So in this case, we could not interpret the PPI. So we are really we are inside the circuit. We are in front of typical counterclockwise flutters. We are pacing from the lateral wall that is a part of the circuit, but because we are not capturing the atrium, that's why we have a false prolongation of the PPI. So be sure that you are capturing before interpreting the PPI. And my message here is to always repeat twice the entrainment in the same site if you have some dots. So this is the maneuver during the tachycardia. So we can, if you want, let's examine together this example. We have here an ECG. We have a counterclockwise ECG surface, but with a faster rate. So we start to pace here from the central isthmus, and you see that the PPI is about 230. It's really longer. The cycle length of the tachycardia is about 190 to 93. We pace also from the lateral isthmus, and in the same time, we have a longer PPI. And when we pace from inside the coronary sinus, we have the PPI equal to the cycle length. In this case, of course, we check the capture, we check that we are sure that we are entraining the atrial flutter. In this case, we can conclude that we are in front of a circuit around the isthmus, the paraseptal isthmus tricuspid here, and this is a feature of intra-isthmus atrial flutter, one of the kind. This example was shown to highlight the important diagnostic maneuver before any ablation. So ablation of the atrial flutter has a high degree of efficacy, and acute success rate is more than 94%. But always some steps are very important. So always check the catheter position, as we explained before. We use a steerable ablation catheter, often with pre-shaped guide-in sheaths. One contacts of the catheter ablation is achieved with the RV. We withdraw progressively until the EGM shows a small atrial and large ventricle with a ratio of 1:4. And then the tip of the ablation is pointed towards 6 o'clock in LAO view. That is the most important. After that, we can start our ablation by applying a continuous energy or use a stepwise manner. The first endpoint of atrial ablation is the termination of atrial flutter. As you see here, during ablation, we have termination of the atrial flutter, but it doesn't necessarily mean that the lane of block is complete. So once flutter is terminated, pacing maneuver should be performed. So here we start a pacing from the proximal CS, okay, with a slow rate. So in this left panel, we have a demonstration of a chevron pattern. It means a simultaneous activation of the proximal and the distal part of the halo catheter because of this counterclockwise wavefront and clockwise conduction through the CTI. So does it mean there is no block and the CTI? Progressively in the middle, we see that we have some delay. We still have some delay with this collision moved more inferolaterally in the halo catheter until we have a descending and purely descending activation from the proximal to the distal with the suggestive of a clockwise block here and the isthmus. So this maneuver could be done also from the lateral wall, and during this maneuver we measure the trans-isthmus interval is a misnamed that reflects right atrium convection time after CTI blocks. So we will try to see from the pacing to the atrial electrocardiogram and the lateral isthmus, the distance here, and that should be more than 150 milliseconds or prolonged of more than 50%. Here is the second example of pacing from the lateral wall of the distal part of the halo catheter. As you see before that the block happens in the CTI, we have a short interval, transisthmus interval, and just after we achieve a counterclockwise block here, we have a prolongation of more than 150 milliseconds, or this prolongation must be prolonged by at least over than 50%. That criterion gives a high sensitivity and specificity of this maneuver. Also, so we have first things, termination of the tachycardia, confirming bidirectional block, and measuring the transisthmus interval. And after that, during ablation, we also pay attention to the local EGM, and complete isthmus block is also indicated by the observation of a double potential that will be clearly separated by an isoelectric segment. It means that you don't have an atrial activity, or if we have some activity that must be less than 0.05 millivolt with an enter spike interval of more than 110 milliseconds. The second, additionally, we can examine the bipolar electrogram polarity reversal is observed in the distal halo and also in the distal catheter ablation, and that reflects the disappearance of the activation by the clockwise wavefront when we are pacing from the CS, as in this example. Unipolar configuration is one of interest. During coronary sinus pacing, we initially have RS configuration, R generated by propagation to the catheter of the wavefront, and S by the propagation away. So when the block, once a complete block achieved, the morphology changes to a single positive deflection, a monophasic R wave, because the recording site becomes a dead end for impulse conduction. So we have no propagation of the impulse here, that stops here, so we have just a positive deflection. During ablation, terminating typical atrial flutter and creating bidirectional conduction block with a correct transisthmus interval is straightforward, but occasionally some difficulties are noticed. Like with a double potential, we can have like a double potential of less than 100 milliseconds, or we can collect some low voltage and fragmented CTI AGM because of some dead end pathway of intraisthmus activity or something like this. So in this case, we need to look for another criterion. So the first one that I will propose it, as you see here in this panel, this is patient that was successfully ablated with no recurrence after that of atrial flutter. But during the study, as you see, we have this double potential with an enter-spike interval of 105 is less than 120 milliseconds if you want, and this intra-isthmic interval also not really longer, not more than 150 milliseconds. So our question here is if there is a slow conduction and a persistent slow conduction through the CTI. To be sure, we have a lot of technique that we can use. The first one is the extra isthmus activation time. This, if you remember, we have here this plateau phase that is corresponding to the isthmus, the trans-isthmus conduction time. And the remaining part is the extra isthmus activation that reflects the right atrium activation. So this interval that we can measure in surface ECG, especially in lead 3, correlates with the post-CTI block activation time and can predict patients who will have a small interspike separation, like in this example, and avoiding useless additional radiofrequency application, and also in order to check for another block criteria. The second proposing things is the differential diagnosis. The differential diagnosis is also proposed to distinguish between complete block and slow conduction through the CTI. So as we see here, we are pacing from the distal part of the halo, and the first potential of the double potential here is ipsilateral. The ipsil is reflects the ipsilateral activation from the distal tip of halo catheter. So when we pace from a seat like this far away, we would have a delay between the spike and the first composite. This is a fixed demonstration that we will have it. This is the first things. So the first component of the double potential will be delayed because we are in the further side away from the first one. But the second component of the double potential depend on the presence or the absence of conduction through the ablation line. If we have slow conduction, the two components will be delayed similarly as you see here. So we have the same delay, we have the same interspike interval, but if we have a real block, the second component will be advanced because the distance of this clockwise wave is shorter than from the tip to the second component. So this helps us to make a difference diagnosis, and also we can use a technique of rate-dependent isthmus block. So with faster rates, we increase the conduction time through the ablation line with change of activation time of the distal halo catheter during coronary sinus pacing or proximal coronary sinus during halo pacing. So with the same concept. So the second things that we could have as difficulties is about the atrial activation sequence. As you see on our right, this activation, we have a proximal distal activation of the halo catheter during coronary sinus pacing, but with here we have a trans-isthmus interval of 178, so something is very good, but this pattern is really not purely descending one. We have like a simultaneous activation of the distal part as some proximal one, I think 9, 10. So in this case, the first things that we should check is the position of the catheter and try to see the position of the catheter, and after that we will see the double potential, of course, and this area, check all the double potential and the ablation line area to see if you have all criteria about widely spaced double potential. So we are in front of a synchronized activation at several poles of the halo with a distal pole activated early or simultaneously than proximal poles. So the question is it a complete isthmus counterclockwise block? Do we have some slow conduction in a clockwise manner here? Do you have some slow conduction here? Or is just like a pseudo feature of slow conduction and we have a little block? So for these cases, we do a maneuver that is named positional pacing. And before positional pacing, we'll take the ablation catheter and we will check or the isthmus ablation line. And as you see here in the and the anterior part, we have widely spaced one, but posteriorly it's slightly shorter. So here we have two things. Two things to be sure about. The position of the catheter, is it posterior or on the eustachian ridge? And the second thing is do we have some slow conduction here? So what we will do, we will make some positional pacing. We will start pacing from the posterior lips of the catheter, okay? So when we pace from here, so the distance from in the counterclockwise will be longer to the tip of the catheter as here. And as you see, the response is a purely descending activation. So we just like modify the atrial activation that we have here. Does it mean that we are not capturing aerial the tip of the catheter here? So it means that we have a real block in the clockwise direction and this isthmus. And to explain this feature, this posterior feature of the double potential here, we will introduce another positional pacing from the posterior wall of the septum. And here what we see just like an early activation, this is the isthmus, and this is the distal part of the hollow. So we will see like an early activation of distal part as some proximal part is just like we are activation distal here, and also we have another activation from here. So this is a characteristic of what is called like a posterior conduction through the inferior crista terminalis. Here we have this nice anatomical structure that is a functional block. It's not an anatomical block. And in some cases, that was reported that in 1/3 of cases, we can have this posterior shunt in the crista terminalis. So here we are really in front of a truly clockwise block through the isthmus, and we have non-slow conduction. The next example here is for another patient. So as you see, the atrial activation in the harrow is really ascending, but what we have just a simultaneous activation here from some pole from here, like this one, if you want, with this one also. So they are simultaneously activated, but the distal part here of the hollow is later. So it's not earlier as the first example. So we proceed the same positional pacing from the distal part of the catheter ablation, and we see that we have a rear block. And from the posterior, and we produce the same things without shortening of the transisthmus interval. So here we can call that we have what is called an upper conduction through the crista terminalis. So these two features are very interesting to know and to understand during our ablation, and that can avoid unnecessary radiofrequency application. So here we have a summary of some difficulties that we can encounter during checking of the block across the isthmus. So we have all the criteria here that we have to check, and sometimes we are in front of an appearance of block, but we still have like a slow conduction. The first thing is to check the position. Why? If the hollow catheter is posteriorly, so we can collect the conduction, the posterior conduction, and we will have like early activation of the distal pole of the hollow. So check the position. That must be anterior and parallel. This is the hollow catheter, the position at air low, and here we have its coronary sinus, but it will be the point, the ostium of the coronary sinus. And just after that, we will do some maneuver to be sure if we have slow conduction or not. As we see together, we have to check the local AGM to see the double potential, widely spaced, no atrial activity. And you could make the differential pacing or positional pacing. And of course, we will check the circuits of the circuits of the macro reentrant tachycardia. And as in the last example, we can have this lower loop conduction, that is responsible of this early or simultaneous deposition of the distal parts of the halo in the counterclockwise feature. The second problem, in the other hand, we can have the inability to get block, but we have no AGM in the local. Really, we have a lot of criteria that suggest a complete block, but we don't. It's not clearly activated through the halo catheter. So check the position. Also, here it's really important, and we have like a short spike interval in the double potential. So here we can use, as you see, the extra isthmus atrial time. This one, because that can expect for some people that it could be shorter, and of course do differential pacing and positional pacing to be sure of this accepted value of this spike interval of the double potential. And at the end, you can have just this lower loop conduction that is responsible of this pseudo conduction that is the posterior conduction through the CTI. In this example, we will have the inducible flutters and with a lower loop. So here we can make like more lateral ablation to achieve a successful ablation in this case sometimes. So, and at the end of our maneuver during ablation, we could check all the feature and all the subtypes of typical flutter for counterclockwise one, that are the lower loop reentry, double or H-shape reentry, posterior variant, and the intra-isthmus reentry. For the clockwise, the variant is the lower loop reentry also. Some difficulty can also be related to the anatomy of the isthmus. So we see before that the central isthmus is our ideal site for ablation, as it tends to be less thick, avoiding AV conduction damage and inadequate ablation in the middle cardiac vein. However, in some cases, with some distinct anatomy and variety, we could have some difficulty. The first one, as you see in this feature, we have a pouch in this middle. It's very frequent, and it's correlated with the presence of the trapezius valve also at coronary sinus. So the problem here, so how can we recognize it? We can recognize it with unusual catheter movement at the tip. And the risk is we have difficult contact, risk of coagulum, and risk of perforation. And how can we highlight the problem by irrigated catheter or sometimes more lateral ablation? The second variety is the extension of this traversing pectinate muscle through the CTI, given more thickness for the central isthmus. So we can recognize it by a large amplitude of atrial AGM, and also the catheter movement that is stuck which between two pectineus muscle. So the problem is difficulty to have transmural region, so we will have a recurrence of atrial flutter and also a wedging of the catheter between pectineus muscle. The solution is the irrigated catheter. Irrigated catheter is the most used solution that can solve the problem very frequently, but if it doesn't work, we can go to more septal ablation. The third variety is the preeminent eustachian ridge. And this one is very particular, and it could be known by the inability of the catheter to reach the septum when we make a clockwise rotation of the catheter. So it's very typical. So here we will have a poor contact in the region between the up of the crest of the eustachian ridge and the CTI, and we should use a given shape here to achieve the ablation in this area. So here we have an approach to difficulty isthmus, and after the diagnosis and after confirming the circuit and the critical isthmus before ablation, some difficulties can be related because it's not a novo ablation. So here we need 3D mapping ablation. And for the anatomy, as we see together, when we have pectinated, we can go to middle ablation, to more middle septally, and use irrigated 8 millimeter. For pouch, go more laterally with a catheter with bidirectional catheter, and for large eustachian ridge, use a sheet and more lateral ablation to achieve success. Thank you for your attention.